Hello, everybody. I'm going to do my NCBI on tuberculosis and coexistent sarcoidosis and tuberculosis. Tuberculosis (TB) is an airborne infectious disease caused by organisms of the Mycobacterium tuberculosis complex. Although primarily pulmonary pathogen, and tuberculosis can cause DI tuberculosis, an airborne infectious disease caused by an organism of the Mycobacterium tuberculosis complex. Although primary pulmonary pathogen, and tuberculosis can cause diseases in almost any part of the body. Infection with M. tuberculosis can evolve from containment in the hosts in which the bacterium are isolated with granulose latent TB infection to contagious state in which the patient will show symptoms that can include cough, fever, night sweats, and weight loss. Since in almost any part of the body, infection with M. tuberculosis can evolve from containment in the host in which the bacterium are isolated with granulose to latent TB infection to a contagious state in which the patient will show symptoms that can include cough, fever, night sweats, and weight loss. According to the WHO, in 2014, an estimated 9.6 million people developed active TB disease, of whom 1.5 million died. The burden of TB is heterogeneously distributed high-income countries, including most countries in Western Europe, Canada, the United States, Australia, and New Zealand, have the lowest rates of active tuberculosis disease, typically less than 10 cases per 100,000 population per year. By contrast, low-income countries have higher rates of TB. Mechanism of pathophysiology. Infection begins when Mycobacterium tuberculosis enters the lungs by inhalation, reaches the alveolar space and encounters the resident alveolar macrophages. If this first line of defense fails to eliminate the bacterium, M. tuberculosis invades the lung interstitial tissue, either by the bacteria directly infecting the alveolar epithelium or the infected alveolar macrophages migrating to the lung's peritoneum. Subsequently, either dendritic cells or inflammatory monocytes transfer M. tuberculosis to pulmonary lymph nodes for T-cell priming. This event leads to recruitment of immune cells, including T cells and B cells, to the lung peritoneum, to form granula B. The bacterium replicates within the growing granula. If the bacterium load becomes too great, the granula will fail to contain the infection, and bacteria will disseminate eventually to other organs, including the brain. At this phase, the bacteria can enter the bloodstream or re-enter the respiratory tract to be released. The infected host is now infectious, systematic, and is said to have active TB disease. Diagnostic screening prevention. For detection of active TB, four main technologies are used. Imaging techniques such as chest X-rays and PET-CT, microscopy, sputum smears, culture-based methods, and molecular tests, whereas imaging tests are used for screening active TB disease. Active TB disease, requires a microbiological diagnosis. It provides an overview of the various diagnostic technologies that have been reviewed and endorsed by WHO. Globally, greater than 90% of newborns are vaccinated annually with BCG, the only current licensed vaccine to prevent the development of active TB disease. BCG vaccine was first used in humans in 1921 and has been evaluated in numerous international trials and observational studies looking at least common manifestations of active TB disease. In clinical trials, the efficacy of BCG vaccine against pulmonary TB in adults has been reported to be 0 to 80%. And now for my NCBI case study, coexistent sarcoidosis and tuberculosis. A 45-year-old black male with a medical history of chronic hepatitis C virus was treated with pegylated interferon and ribavirin until 4 months before hospitalization was admitted for bacterial pneumonitis. On examination, the examination revealed neck, mediastinal, and abdominal adenophysitis. Sorry, guys. Historically, Ziehl-Neelsen negative necrotizing granulosis mitosis reaction was documented in a later cervical lymph node analysis. The Montauk's test was negative, and bronchoalveolar lavage showed a lymphatic alveolitis 60% of the total with a CD4-CD8 ratio of 4. Angiotensin converting enzyme was elevated, and there was no sign of uneval involvement of hyperchlorhydria. Microbiology examinations for mycobacteria was repeatedly negative. Even upon examination of a culture on respiratory and peripheral lymph node tissue, a provisional diagnosis of sarcoidosis was made, and the patient was discharged with a follow-up schedule without therapy apart from oral antiviral drugs. 3 months later, the patient came to the Department of Infectious Disease of the hospital complaining of a high-grade septic fever and bilateral pleural effusions. A thoracic and abdominal CT confirmed few nodular elements in both lungs, along with confirmation of pericardial and bilateral pleural effusions and multiple spleen nodules. The analysis of the pleural fluid was unremarkable apart from prevalence of lymphocytes upon cytological evaluation, as the patient was prostrated for long-lasting febrile manifestations. The induction of steroid therapy led to the resolution of fever. Chest X-rays showed that different evolution of pleural effusions with simultaneously improvements on the left side and worsening on the right side. The positron emission tomography CT examination confirmed multiple areas of a high 18-fluorodeoxyglucose uptake at pleural surfaces, systemic lymph nodes, and spleen. The patient was referred to the interventional pulmonology services with the aim of performing a medical thoracoscopy for a definitive diagnosis. Geographic pleural thickening with multi colorations and granulomatous necrotizing disease at the level of the pleural tissue was present. However, Ziehl-Neelsen colorizations were again negative, as were polymers chain reactions analysis for tuberculosis. The positron emission tomography CT examination confirmed multiple areas of a high 18-fluorodeoxyglucose uptake at pleural surfaces, systemic lymph nodes, and the spleen. The patient was referred to the interventional pulmonology services with the aim of performing a medical thoracoscopy for definitive diagnosis. Geographic pleural thickening with multiple multicolorations and granulomatous necrotizing disease at the level of the pleural tissue was present. However, Ziehl-Neelsen colorization was again negative, as were polymers chain reactions analysis for tuberculosis. Fluoroscopic view, which is A, which is on the left side of the right pleural cavity, showing disseminated fibro fibron fibrinosus pleural thickenings and multiple multicoloration. Pathophysiological examination of the pleural biopsy, which is B, which is on the right, revealing a granulomatous cascading necrotizing pattern. Quantiferin positivity, together with the endoscopic scenario and the histological pattern, motivated the introduction of antimicrobacterial treatment and the withdrawal of steroids. High-grade fever reappeared and an increase of GGT, nausea, and abdominal pain were reported. Circulating CD4 were 173 cells, YL, and the HIV test was negative. 20 days later, steroid reintroduction dramatically improved the fever and overall clinical scenario. Lymphocyte CD4 increased to 391 cells YL 2 weeks after steroid introduction. The positivity of cultures on pleural specimens for Mycobacterium tuberculosis was reported 45 days after thoracoscopy, leading to confirmation of pleural TB in the framework of the concomitant system sarcoid manifestations. The next two slides have all the medications that I mentioned in the previous slides, and it has their mode of actions uh, and all the stuff that we normally need to look up. Thank you guys. Have a good one.